I'm Ann Curtis, the Charles and Mary Bauer Professor and Chair of the Department of Medicine at the University of Buffalo. I am also the principal investigator for the BLOCK-HF trial, which was a prospective, multi-center, randomized national trial that went on for 8 years and enrolled over 900 patients to study a new treatment for patients with heart block and heart failure. And what BLOCK-HF is a national study that was looking at the best way to pace patients who have block in the heart's electrical conduction system. The heart has a normal pacemaker at the top chamber of the heart. Impulses are supposed to travel through the top chamber, through the node in the middle of the heart called the AV node, and then the conduction system is like a tree trunk and branches that rapidly sends impulses out to the bottom chambers of the heart to allow them to contract in a synchronized fashion. Well, a standard pacemaker is designed to correct a problem when there's a block in that electrical system by having a lead in the top chamber and a lead in the bottom chamber. So it gets around the blockage and allows the heart to be paced and to beat again in a fashion that allows blood to flow through the body. The problem with a standard pacemaker, though, is that it only paces the bottom of the right side of the heart, the right ventricle, and then impulses have to travel more slowly through the rest of the heart. And so the left side gets activated late, and when it gets activated late, instead of having everything activated simultaneously and beating simultaneously, there's a lack of synchronization. So we've been concerned that that lack of synchronization in patients who have this block in the electrical system and any degree of heart failure to start with, or any weakness to their heart muscle, might make them get worse over time. So that's what BLOCK-HF was studying. We put pacemakers in patients, or implantable defibrillators if they had a need for that. And what we did was we put a lead in the top chamber of the heart, as we usually do, and then put 2 leads in the bottom chamber, one in the right ventricle and one over on the left side of the heart. And then half the patients had only the right-sided lead turned on, and the other half had both leads turned on, and then we followed them to see what the outcomes would be like. And what we found was that if we looked at a composite endpoint of mortality, heart failure urgent care, so where patients developed symptoms of heart failure and needed intravenous treatment, or worsening of heart function by echocardiography, that pacing both sides of the heart led to a 26% reduction in that endpoint compared to the standard way of pacing the heart. What BLOCK-HF did was take all of these patients from anywhere from mild to moderate to more severe heart failure and showed that pacing both sides was better than just pacing the right side alone.